Okay, this is a brief presentation on the genetics of dystrophinopathies. We're going to talk about Duchenne's and Becker muscular dystrophy as well as myotonic dystrophy. So dystrophinopathies, dystrophin is a protein important in the complex that connects the muscle actin to the extracellular matrix, including the lamina. The complex is important in both the movement of skeletal and cardiac muscle, and when the dystrophin does not stabilize the muscle unit to the extracellular matrix, every time the muscle contracts, it results in damage to the cell membrane. So Duchenne's muscular dystrophy, when the dystrophin protein is non-functional, usually there's no connection to the cytoskeleton. In most cases, Duchenne's, there's actually no dystrophin produced. So there's no dystrophin here. As a result, every time the muscle contracts, there's damage to the cell membrane. Creatine kinase is a source of energy. When there are rips in the cell membrane, the CK can migrate out into the bloodstream. Elevated CK in the bloodstream is a sign of muscle damage. It doesn't tell us exactly what the problem is, but it's a sign of muscle damage. CK is an important source of energy, and depletion of CK from the muscle cells can decrease some of that energy that's important in making energy. When there's, but the major issue is when there's openings in the cell membrane, calcium can migrate in, and calcium can activate proteases, and proteases break up muscle. So that's actually the calcium is usually very closely monitored and regulated at the cell membrane because of this. And so when there's openings in the cell membrane and calcium can just freely flow in, it's activating proteases and progressively destroying muscle. When I once saw a 2-month-old who had a family history of Duchenne's muscular dystrophy, and his CK was 25,000. He had absolutely no evidence of muscle weakness. The common age that I would diagnose with symptoms a child with Duchenne's muscular dystrophy is about 6 to 8, and they usually have a CK of 8,000. Normal is like 50 to 100. So the infant actually has 20,000. The 7-year-old has 6,000 or 7,000. And if I were to see a 16-year-old that's in a wheelchair because of being ravaged by Duchenne's muscular dystrophy, his CK might be 1,000. Well, why does it go down? It goes down because the calcium has destroyed so much of the muscle that there's not much muscle left, so there's not much muscle to even release CK into the membrane. So clinical characteristics, again, it occurs in about 1 in 5,000. Typically, it's seen in males. It's inherited from a gene on the X chromosome, which we're going to talk about in a second. Features include progressive muscle weakness, calf hypertrophy, and the reason the muscle weakness is progressive is because we're progressively losing muscle because of the proteases. Toe walking, lordosis, so you can see this progressive lordosis. And patients usually become wheelchair bound by around the age of 16. Death usually in the late teens to early 20s because of heart failure or dilated cardiomyopathy. On physical exam, muscle weakness in both the upper and lower extremities is identified, but it's more of a proximal weakness greater than distal. So proximal, difficulty standing up from a chair, difficulty going upstairs. There's enlargement of the calves, and this is believed because as we lose muscle, it's being replaced by fat, and that's why the calves get enlarged. One of the early descriptions of Duchenne's muscular dystrophy is something called a Gower sign, and when the child stands up, normal kids, you put them on the floor and they hop in a single motion, like to a standing position. But children with Duchenne's have to literally crawl up their legs. Sometimes if, when I'm trying to see this, I make sure there's not a chair or something near them because they find ways to do things. They'll They'll pull up on a chair, they'll pull up on a bench or something like that. So you need to put them on the floor, not around anything. And the only way they can get to a standing position is to crawl up, literally use their legs for strength. And so here's a little boy. He's about 3 or 4 years old, and you can see how he crawls up his legs. There's another video that's a little older child that's even more obvious than that. Dilated cardiomyopathy, as I was saying earlier, this is the #1 cause of death in patients with dystrophinopathies. Systemic muscle weakness can also affect the cardiac muscles, and it results in enlargement of the heart. And bigger is not necessarily better. And in left hypertrophic cardiomyopathy, this part of the heart enlarges, but with dilated, the entire heart enlarges like a big balloon. And the left ventricle doesn't do a very good job extruding the blood into the bloodstream because it's so weak. Dilated cardiomyopathy occurs in all patients with both Duchenne's and Becker's muscular dystrophy, and it's the most common cause of death in this group. So Becker's muscular dystrophy, you have to remember these things, especially when they're named after people, were clinical diagnoses. We did not know what caused them. We didn't know about genes or anything. And clinically, a patient with Duchenne's muscular dystrophy that was described by a Dr. Duchenne, presented between 3 and 6 years of age, and a Becker's a little bit later. And so they always knew they looked very similar to Duchenne's even before we knew the gene. But Becker's actually results in the same, it's the same gene. It's the dystrophin gene. The difference is in Duchenne's, in most cases, it's the complete absence of any protein at all, any dystrophin protein at all, whereas Becker's is usually more of a missense mutation, and you do get some protein, it's just not as long as it should be. So it's altered, but has some function. It's a milder phenotype than Duchenne's and has a later onset. And one of the differentiating features clinically is neck flexor muscle is preserved in Becker's versus Duchenne's. Patients with Becker's are usually wheelchair bound by their late teens, and death between 20 and 40, again, usually by dilated cardiomyopathy. So as I said earlier, the gene dystrophin is located on the X chromosome, and males only have 1 copy of this gene. So if it's not functioning, that's all they got. Females actually have 2 copies of the gene, one from one parent that's functioning and the other parent that's not. Females have random X inactivation. So we used to say, and when I went to medical school, and up to 5 years ago, if a female is carrying 1 copy of this Duchenne's gene, she's fine. She's just at 50% risk of having a son with Duchenne's. Or if she had a different type of mutation, Becker's, it's true to form. Like if she had a missense mutation, she might get a Becker's. Or if she had no, gene product, it would be more of a Duchenne's. But she would never have any symptoms, and we've since realized, no, we're wrong about that. And it has to do with X inactivation. So yes, there's random X inactivation, but if 30% of the heart had, if 70% of the heart had the non-functional copy of the dystrophin as the active copy, then you're going to have a significant amount of dilated cardiomyopathy. And the majority of females do develop, that are carriers for Duchenne's, do develop symptoms of dilated cardiomyopathies, usually later in like their 50s. And some do show some sign of muscle weakness. So it needs to be monitored for. So the dystrophin gene is one of the largest human genes. It consists of 2.4 million base pairs and 79 exons or coding regions. Mutations of the gene result in no protein or nonsense or abnormal protein missense in about 25 to 35% of patients. But a deletion of the entire gene occurs in between 60 and 85%. So a deletion of the gene is very common, or a missense mutation where there's stop codon. But in most cases, there's a problem with exon 51, which is right over here, right near this hinge. Now, I know pathology and a lot of the other people talked about the diagnosis for Duchenne's muscular dystrophy is by a muscle biopsy. And historically, that's true, and you do need to know it. However, when we suspect Duchenne's because of a positive Gower sign and an elevated CK, so if the CK is normal, if we're worried it's normal, then we're done. But if it's elevated, you know, here's these two things: delete, you know, genetic testing or muscle biopsy. Even if you get a positive muscle biopsy, you still have to get gene testing because of, we're going to talk on the next, because the gene mutation is actually important in treatment. It costs about $10,000 to go to the OR if you're just going to get a piece of muscle so you can stain it. So it's actually far more cost effective to do genetic testing. This gene is a very large gene. In like 4 or 5 years ago, it cost like $5,000 to do it. It's now a couple hundred. So this is actually the best way to go, because even if you got a piece of muscle, you still have to do gene sequencing to confirm what the mutation is. So if you did staining and didn't see dystrophin, that only gets you so far. You still need to do gene sequencing. So it's probably best, if you have the suspicion, to do a cheek swab or a blood draw over sending them to the operating room. Management, physical therapy. Well, again, it's a progressive, you're continuing to lose muscle, so you're not going to get very far. Steroid injections into the muscle have been shown to increase muscle strength and function because it helps the inflammation. Cardiac medications to improve cardiac function. But there are a number of studies looking at future therapies. And one that's actually FDA approved, it's not even research, is something called exon skipping. Approximately 80% of patients with Duchenne's muscular dystrophy have a deletion, duplication, or mutation involved in exon 51. The phosphodiamerate morpholino oligomer, or I call them PMO, charged analog, binds to the mRNA. So after we make our RNA, before we do splicing in the nucleus, we add this PMO, and it blocks between 48 and 52. Therefore, if there's a deletion or a stop codon involving exon 51, it splices from 48 to 51. So normally we get a normal dystrophin. When we have a either nonsense mutation or missense mutation involving exon 51, we get no dystrophin. But here we get some, but it's not quite as long as normal. So maybe we're making a Becker's out of Duchenne's. So it's shorter, but it does have some function. And this is actually, the most common is 51, but there are a number of other areas that there's actually a medication for this. They're working on others for, exon 47 and things like that. But this is what exon skipping is blocking the splicing, which occurs in the nucleus after we make our RNA, so that the transcript that ends up, the final RNA that goes out into the nucleus to get out of the ribosomes, is back in reading frame. And the PMO is given by IM injections weekly. Again, it's not a cure, but it's a better treatment than anything that we've had so far. But it's also dependent on the gene mutation. And that's why staining will tell if you don't have any dystrophin. But you still need molecular testing for actual management. So the next disorder I want to talk about is myotonic dystrophy. And myotonic dystrophy affects skeletal, cardiac, and smooth muscles. Muscle weakness begins with face and spreads to distal limbs, and cardiac arrhythmias can also be an early symptom. Again, the heart is the most important muscle of our body. So clinical characteristics include kind of a long face, ptosis, the eyes aren't open, inability to release a grip. So sometimes they be shaking hands and they don't let go, or they won't let go of a doorknob. Males often have early frontal bossing, and I just want to show you, this is a 18-year-old, and you can see this this hair loss here and the long face. Early features include early cataracts, type 1 diabetes, and hypogonadism. Myotonic dystrophy is inherited in autosomal dominant fashion. It occurs in about 1 in 500 individuals, so 10 times more common than Duchenne's. And it's caused by an increased number of CTG repeats on the 3' end of this gene. And this results in the gene not being transcribed. So this increased number of repeats results in the gene not being correctly transcribed. But the more the repeats, the worse the outcome. So 50 to 200 is adult onset, which is a classic, which I just showed you in the last slide, that they have symptoms as an adult. They start having, frontal balding and long, facial weakness, cataracts. 200 to 800 is late adolescent, which was the first 2 kids that I showed you that also have some cognitive delays. And then greater than 1,000 is an infantile. So here we have, there's something called anticipation. And anticipation, especially with these triple repeat disorders, the disorder can get worse from one generation to the next. So grandma maybe has 100 repeats and has late, early onset cataracts. Her daughter kind of has this long face with some ptosis, but her baby has the low muscle tone and the tongue hanging out, or the infantile myotonia. So it gets worse from one generation to the other. In most cases, this expands, becomes unstable during oogenesis. So again, late onset, greater than 50 repeats, cataracts, muscle weakness, usually it's pretty subtle, between 40 and 100, classic, between 12 and 50 with low muscle tone, especially distal. So remember I talked about proximal for Duchenne's. This is more of a distal muscle weakness. And between 100 and 1,000. Childhood, 500 to 2,000. Learning disabilities, long face, low muscle tone. And then the fetal, between 1,000 and 5,000. So a 5-year-old male is having difficulty rising from the floor. He cannot ride a 2-wheel bicycle. His mother has a brother who died from complications of Duchenne's muscular dystrophy. What laboratory study would determine if he's likely to have the same disorder? And the correct answer is creatine kinase, or CK. And that completes this small lecture.